good afternoon, everyone. Let's get started. So, hoping everyone was able to digest everything. Not your lunch, the whatever we covered in the first lecture. Are there any questions regarding what was covered? I mean, we'll have a QA session and a clarification session towards the end. But if there's something that you would like to discuss before we get started, let me know. If not, we can jump right into our material. Okay, so we'll try to follow oh, there is one question. Okay, sorry.
Sir, I have seen that this college is for 2D. The matrix is for 2D.
Okay.
But how do we proceed with the 3D? The tumor is not restricted to a single slice, but
Right,
it's But how do you construct the collective volume of that tumor?
So just for simplicity purposes, what I showed earlier today in the slides, I showed in 2D. But if you read the paper, we have a 3D implementation as well.
Actually, I have seen, sir, but I couldn't able to understand what exactly. Is
so okay, so let me try to clarify that. So if it's a 2D image, so let's say that when you're computing your features, doesn't matter if it is collage feature or some other radiomic feature. End of the day, what you're doing is you have a filter. So you take a filter and you have to convolve. So for those of you who are used to deep learning, it is quite straightforward for you. But for those of you who for you guys who haven't worked on this so far, so typically the underlying operation for this is convolution. Okay, so or multiplication. And here, if it's a 2D slice, you have a 2D kernel. You basically have to have a sliding window. You multiply the images with your values over the sliding windows, right? Now, if it's a 3D image, what changes is instead of a 2D kernel, you will have a 3D kernel. So instead of a 3 cross 3 matrix, you will have a 3 cross 3 cross 3 matrix, right? So think of it as a cube instead of a square, and you just move that cube and do your convolutions. That's it.
But does that changes the complexity of the mathematical operations lies inside it?
I mean, yes, it will. But eventually, since these are 3D images, that's what we have to do, right? I mean, like you rightly said, the information is not restricted to 2D slices. So if you compute these in 2D, you will lose the information in the slices above and below. So if you want to do a proper calculation of the heterogeneity, you have to do it in 3D. It does increase the complexity. It will increase the time that's required. But I think a true let's say characterization of the changes in the image intensities can only be obtained if you do it in 3D.
Okay, thank you.
Yeah, good question. Anyone else?
Sir, regarding the collagen, we saw that on the basis of for a medical imaging, so we have three characteristics like the intensity, shape, and the texture based analysis.
So these are the basic three, but there can be more than that.
Yeah.
Yeah.
For entropy calculation that you had shown, there are different intensity.
Right.
So how does the model determines that? Like on what basis is that calculated?
Okay. So you want the easy answer or the more difficult answer? So you're a PhD student or master student?
Masters.
Okay. So differentiation, right? So essentially you have changes in intensity along the x axis and along the y axis. You have to look at how many, what is the change in intensity along each of these directions divided by how many, the delta x, right? Or delta t rather. So here you don't have a t, you have the distance, right? So that's what you do, right? So essentially you compute the change in intensity using a differentiation, and depending on how many. So when I said a 3 cross 3 kernel, it doesn't have to be a 3 cross 3 kernel. It can be a 5 cross 5 kernel or a 7 cross 7 kernel, depending on how much information you want to consider along the x direction and the y direction. Okay, so based on that, it changes. Okay.
Yes.
I think there was a question there on that side. Yeah.
Yeah, so my question is, I think, continuation with what was asked. So what are the template methods that are used to kind of normalize the intensities? Like, are we going to cover that in this?
Normalize the intensities. Okay, so I'm not covering that here, but I can tell you a little bit about some of the methods that we use. So one of the simple but very powerful methods is called piecewise histogram matching. So what you do is you have a distribution of your intensity of your, let's say, your template image or your source image, and then you have a target image. You want to map the target image intensity to the source image intensity. So what you do is, so you have this intensity distribution, which can either be a Gaussian or it can be any distribution. So you piecewise divide that histogram and you match or you map the portion of the target to the source, right, and you do it in a piecewise fashion. So you can either do a global matching, but if you do a local matching, it ensures, okay, so let me try to rephrase this in a way that makes sense from a medical image perspective. So let's say that you have a brain MRI image. So in a brain MRI image, you will have components like gray matter, white matter, and then you will have cerebrospinal fluid. So all of these different tissue have different intensity ranges. Now if you try to map one brain intensity histogram to another brain intensity histogram, it will be a global matching without really accounting for each of these tissue compartments. But if we further divide it into these piecewise compartments, then it will make sure that the distribution of the white matter matches the distribution of the white matter, gray matter matches the distribution of gray matter. So that's something that can be done. So that's one of the simpler ways, and it's very powerful, very effective. So another way, another technique that we apply is called matching or trying to register everything to an atlas. So for example, for brain images, what you would do is, so you would construct an atlas from healthy images, patients who do not have a disease. By atlas, the reason we do an atlas is because otherwise, if you match one image to another image or one patient to another patient, how will you know which patient to select as a template, right? So we create an atlas. If we create an atlas, what will happen is, if let's say that you create an atlas from 100 healthy brains, that would mean that if there are small imperfections in each of the healthy brains, by taking an atlas, what is an atlas? An atlas is just an average. So if you take an average, you will average out any sort of errors that are there in the individual images. So you create one image which is an average of 100 images. That is your template image. Now when another image comes in, you can map it onto that healthy image, and that can be done using a lot of methods such as piecewise deformation, diffeomorphic registration methods or other kinds of registration methods. And when you do that, it will also normalize other sorts of inconsistencies that might be there. Okay,
Thank you.
okay, so if there are no further questions, let's start this. So who's this gentleman in this figure, in this image? Anyone? Yoshua Benjo, and he is well known for. Okay, so he what did he win last year? He won the Nobel.
Nobel. Okay.
Yes, he won the Nobel. I mean, obviously there are yes. So there are there can be debates about whether they should have won the Nobel or not, whether it actually qualifies as something that is worth a Nobel Prize, but that's different. Let's not get into that. But end of the day, he and a couple of other people, they're really well known for the field of deep learning. So what this article tells you is that researchers like him and others, they want their algorithms to understand the why, right? It's not just giving you an answer as to whether it's a tumor or whether it's benign or whether it's disease A or disease B. Why does a model decide, or how does a model decide that it's a tumor or it's benign, right? So we want to understand, we should be able to decipher the why right? So because deep learning is fundamentally blind to cause and effect. Unlike a real doctor, a deep learning model cannot really explain why a particular image may suggest disease. I wouldn't say that it cannot explain. I mean, that's the research part here. What we do in our labs and many other people try to do is to understand why this is happening, but fundamentally a deep learning algorithm cannot explain it. So this means that deep learning must be used cautiously in critical situations. So here's a famous quote: "I have an extremely large collection of clean labeled data." Who said this? Come on, it's easy. No one. Okay, so we never have an extremely large collection of clean label data. If we had that, I don't think half of us would be doing the research that we are doing, right? So a lot, I think one of the when I started my lecture earlier today, one of you here mentioned that they want to learn about how to build these models when you do not have enough data. And it's not just about enough data, enough clean data. You can have a lot of data, but if that data is not clean, if you just throw that data blindly to a model, throw a kitchen sink at it, you will not get good results. It's garbage in is garbage out, right? So we don't really have an extremely large collection of clean label data for, and this is mostly true for medicine. Maybe in the real world, if you're familiar with the ImageNet data set, where you have hundreds of thousands of images of real world entities like cats, dogs, different kinds of sceneries and whatnot, you can have a very large collection. You probably don't need a lot of clean data, but at the same time, you should understand that the repercussions here are much higher, right? So eventually, what we want out of models that are in the medical domain is very different from what we want out of models in the non-medical domain. So by the way, just a quick question: why do you think having a large, clean, perfectly labeled data set is an unrealistic assumption in clinical imaging? So why do you think this is not possible? Why do you think it's difficult? Yeah.
Because sir, label data are very costly. Like for annotation also, we need some domain expert to annotate those data, and in real life or in medical case, it is very kind of a very gold mine for us.
Right.
We cannot get this kind of thing.
Okay, thanks. So I'll try to simplify that. So let's say that you want to train a machine learning model to, is it Christmas today or yesterday? It was yesterday, right? So I remember when I started my, when I trained my first machine learning model, that model was to detect if a Santa has a reindeer or not, something like that, like if Santa is sitting on their sleigh, on his sleigh or not. So there were a lot of images, and I had to go and divide these images into different folders: Santa on sleigh, Santa without a sleigh, right? So I had to do that, and I could do that because I know what a sleigh looks like, what Santa looks like. I didn't really need a domain expert, right? But if we were to collect a data set or curate a data set that had some kind of a rare tumor or some sort of a disease that is observed on some medical imaging modality, we would need an expert to curate that data. I mean, yes, you can argue that there's a lot of crowdsourcing that's happening where you give these images to non-experts, have them annotate, and eventually the model that you figure out, that you train, will figure out who's an expert, who's not an expert, but we're not going there. To train a machine learning model, the fundamental assumption is that you have good data and good label data. So getting good label data means that getting good labels, and getting good labels means you need to have some expert who annotates these labels for you, right? So if your goal is to build a machine learning model to detect tumors or to segment tumors, or let's say your goal is to build a machine learning model, and I'll talk a little bit about ophthalmology. So you have fundus images, and in fundus images you have different kinds of primitives like blood vessels, for example, or microaneurysms and so on. who are non-domain experts, we can't figure out what pixel is an aneurysm, what pixel is not. Maybe you can do that after you are exposed to many of these images over a long time, but we can't really expect us non-experts to do that. We will need an ophthalmologist to look at these images, right? And getting their time, getting that kind of effort from them is very difficult, right? So everything has a price to it. So it's very expensive. So that's why it's an unrealistic assumption in clinical imaging. What else? Why else do you think this is an unrealistic assumption?
Probably the differentiation between, or maybe intravariability or intervariability of like doctors. Maybe some people like might have a different assumption of
Right. Okay, that's a very good point. So what he's trying to say is that, so there might be, so it's a very subjective thing. A lot of times the way doctors give the decisions might be subjective, and let's say that there's some sort of a condition where doctors are not 100% certain, right? So one doctor may tell you that this is a particular kind of disease, another doctor might tell you this is another disease, right? So there's a lot of variability in there, and that further reduces the confidence that we have in building these data sets, as opposed to if you were building a cats versus dogs data set, a cat is a cat, right? Unless you are asking ChatGPT to create a cat that looks like a dog, right? So and yes, you can do that, and we have shown that something like this is important. I'm just trying to go out of syllabus here. So if you do that, what we have shown is we have asked, or we have trained models that generate cats that look like dogs, and then using methods like self-supervised learning, we teach a model to find out how much % of that is cat and how much % of that is dog. And if you can do that, then your model is learning the characteristics of a cat and a dog, right? So then it becomes a very good model, right? But yeah, so out of syllabus. Yeah. So yeah, having a large, clean, perfectly labeled data set is unrealistic. Another reason is, a lot of times if you want to train a model, let's say that there's a very rare cancer where maybe you have not even hundreds of cases, maybe 10 cases in the entirety of the country, or maybe 100 cases throughout the world, right? So how will you even get a big data set to train a machine learning model? It's difficult, right? So just the nature of the problem makes it super difficult, super complicated to assemble a clean, perfectly labeled data set. That's why for those of you who are familiar with NeurIPS, the NeurIPS conference, which is one of the most famous machine learning conferences, they have a datasets track. So because datasets are so difficult to curate, they have focused one of their publication avenues as a dataset track, so that people who are working on new datasets, I know someone here, you're working on aerospace, right? And also there are people who work on satellite imaging, for example, and a lot of these new domains are coming up where you do not have enough data. So if you think that you have this data set that that other researchers can use, a lot of these conferences are beginning to accept papers like that. I mean, obviously it cannot be just, okay, here's my data set, here's the paper. It has to be what can be done with that data set, right? What sort of benchmarks you can run on that data set. So data sets, very important. So the goal that we have been pursuing in our lab is that we want to go from purely data-driven models. By purely data-driven models, what I mean is, you have your deep learning model, you have a certain architecture, you throw your data at it, you try to get your results. Even high school students can do that. We don't want to do that. So what we want to do is, we want to go from purely data-driven models to models that are data-informed and domain-inspired. By domain-inspired, what I mean is, actually bring in clinical domain knowledge. Since we are talking about medicine here, how do we bring in clinical domain knowledge to machine learning models, or to training these machine learning models? So here are some of the imperfect data scenarios where clinician AI collaboration is extremely important. Missing modalities. So we looked in the previous lecture, we looked at how we need T1 scans, T2 scans. A lot of these models, like UNet models, for example, they need different modalities or different protocols to be able to generate proper segmentations of tissue. In that context, we looked at tumors. But what if you have certain modalities or certain protocols missing? And this is true for all domains. It doesn't have to be just medical domain, but it becomes more crucial in the medical domain because we have it's inherently multimodal, right? So medical domain is inherently multimodal. Costly annotations, we covered this. Scarcity of data sets. So we are again touched on this. You might not have enough data sets, so that becomes an imperfect data scenario. Unpaired data. So let me talk about this a little bit more. So by unpaired data, what I mean is, so let's say that you are looking at developing some personalized decision support system which needs RNA data and some imaging data, right? So in order to train a model, you would want to have paired data. For the same patient, you need to have RNA data. For the same patient, you will need to have imaging data. But what if pairing this data becomes infeasible? Or what if there's, for some images, for certain patients, you have paired data, certain patients you do not have paired data. So there can always be instances where where pairing is not possible. And then complex reasoning, and some of these complex reasoning stems from the fact that these images are very complicated, they're very heterogeneous, there can be differences in there's subjectivity in the clinical reasoning. Like I mean, let's say you have Dr. A who arrives at a particular decision, and Dr. B arrives at the same decision, as in the model output, not the model output, the clinician diagnosis is the same, but the way they arrive at the decision is different, right? So that becomes a very challenging problem. So these are the few of the different kinds of imperfect data scenarios where we need proper collaboration between clinicians and AI. So how do we address this in our lab? So we bring in domain knowledge, and domain knowledge can be in many different forms. It can be as clinical intuition, where you can build features like domain-inspired radiomics that we saw in the earlier lecture, domain-inspired pathomics that we'll see tomorrow. Expert interpretation, where we can build generative tools, and human-in-the-loop model. So this is very important. So we can consistently and continuously take input from clinicians, keep them in the loop, and try to fine-tune models based on their confidence and their certainty. And we can do uncertainty analysis, some data-driven insights where you look at the model output, you quantify the uncertainty, and then you see which of these samples are, let's say, highly uncertain, less uncertain, and change the outputs, provide it back to the system. So it's a form of an active learning. So that's something we can do. And also viewing patterns. So I'll talk about this later today, where you can build systems where you try to understand how the radiologist is looking at certain images, how the clinicians are looking at that data, and try to build modules within your ML framework to emulate their decision making process. And that's something that we can do via gaze analysis. I'll cover this as well towards the I think end of this lecture. Okay, so now I'll start going through the different use cases. So the first use case that I'll be covering is predicting COVID-19 lung infiltrate progression on chest X-ray scans using some machine learning model that we developed. And in this particular case, we used spatiotemporal LSTM. Did not have transformers back then. Otherwise, we would have approached it differently, obviously. So okay, what's the goal here? What's the clinical problem? So this was actually right during the beginning of COVID-19, where if you remember, if any of you have gone through a lot of the literature that was being published, people started publishing papers like crazy. I mean, every day you would see hundreds of papers coming out on how to identify COVID-19, what's going on, what's not going on, and stuff. But what was important, and what we realized was missing, is that there were not much work going on where people try to understand, researchers try to understand how this model is, how the disease is progressing, because that's where we would add value to the decision making workflow, right? Just saying if it's COVID, it's not COVID. I mean, yes, I think clinicians can, or back then radiologists could just look at the X-rays and say it's COVID or not, right? So just detecting COVID wasn't the challenge here. So none of the works back then had investigated or studied the spatial distribution within the images and the temporal information of how the disease progresses. So we realized that there was an unmet clinical need there, there was an unmet gap there that we wanted to address using our machine learning models. So the goal was to provide imaging evidence of disease improvement or disease deterioration on sequential imaging data. So what you see on the screen, going from left to right, we have a image of a patient's chest X-ray that was acquired on the day they were actually admitted for COVID-19. You don't really see a lot of infiltrates here, but if you look at another day, this might not be day 2, it might be day 3 or day 4. You see that there's a lot of COVID infiltrates in this region. It further gets filled up, and then towards the end, which was after n days, you see that the COVID infiltrates have resolved. So the lung becomes clearer. So you see how it starts from being a little dense to a lot denser, and then it becomes clearer, right? So you see that there is some pattern in which this disease is progressing. So the goal was to study how the disease progresses. How did we do that? So first of all, data set. Like I said, getting data sets are extremely difficult. So let me actually tell you a little bit of slightly segue and tell you something else that we observed during this period. A lot of the research that happened back then and a lot of the papers that were published, I would take all of that with a little bit of with a grain of salt, because a lot of papers, what they did was they were like, okay, we had a data set of tens of thousands of images, we trained a machine learning model to detect COVID-19, to distinguish COVID pneumonia from regular pneumonia, and so on. But if you look at how the data set was collected, and there's an important lesson in this for anyone who wants to get into medical imaging, if you are already not in medical imaging, you need to understand the source of your data, right? So in this, but why I'm giving this example of this COVID-19 of these papers is that a lot of times the images that were taken to train the machine learning models were scraped from the web. So basically, there were clinicians who were publishing papers and the PDFs were out there. People would take the PDFs and scrape the images out of that and use that for machine learning model training. That's not how we should be doing these or training these models, because if you look at it, so let's say that you have a native X-ray, native scan, which is collected using some G scanner or Siemens or Philips scanner. The format in which these images are saved is called a DICOM format. Okay, so these are not PNG images, or these are not JPEG images. A lot of times, if you look at JPEG images, so JPEG images, there's some sort of a lossy compression going on. So you lose some intensity information, some pixel information in those images. Now imagine a paper has been published, it's there on archive or it's there on the web. If you further scrape that image, there's so much loss in information. You lose maybe 90% of that information, and you try to train a machine learning model with that with that quality of an image. Obviously, like I said, garbage in is garbage out, right? So most likely those models don't even mean anything, right? So that's why we have to be very careful in which in the way we collect and curate our images. So for this particular problem, we collected sequential X-ray scans from 93 COVID patients. We didn't have a huge data set. We had only 93 patients, and we had 600-ish scans from them. Now 600 because multiple scans per patient. We were studying the progression of the disease. Also, it's important to realize that, and this is where that pairing of data comes into play. If you remember, it looks like there's approximately 6 scans per patient, right, based on the ratio that you see here, but that was not true. Some patient had 3 scans, some patient had 20 scans, right? So there was a variability in the number of scans, in the number of temporal scans per patient. Okay, so what I hope you can see this. So what we did was the first step of annotation, and this gives you an idea about why it is difficult, why it is very time consuming and expensive to get these annotations. First of all, we used a machine learning model to identify the boundaries of the lung. So this bounding box that you see here, so this is actually the left lung. So typically in MRI scans or in radiology scans, it's inverted. So this is left and this is right. Okay. So this is your left lung that you see here, and we divided the lung into 3 different zones: the upper zone, the middle zone, and the lower zone. And we worked with our collaborating radiologist. We asked them to look at the severity of the COVID infiltrates, and they gave a rating of 0, 1, 2. 0 stands for no infiltrates, 1 stands for medium infiltrates, and 2 stands for heavy infiltrates. By infiltrates, I mean you see a lot of COVID patterns. So basically, the disease getting lodged in that part of the lung. So in this particular example that you see here, you have 0, 1, 2 on the left and 1, 2, 2 on the right. And we asked them to do this for each of the 620 odd scans that we had. And you can imagine how much time taking this is, right? How much time consuming this is. Now, what did we do here? So what sort of a model did we develop? So we developed a LSTM based framework, a long short term memory framework. So what this framework does at a very high level is it retains in memory what it saw previously, and it brings in the new context. So there are two different things that we wanted to study. First, within a given lung, how much is the change in the patterns from the upper lung to the middle lung to the lower lung, and between the time points, what are the change in patterns. So there are two levels of patterns that we want to pattern changes that we want to study, right? So first we had a spatial temporal block, a spatial LSTM network, where we looked at how the patterns were changing within each of the zone or each of the zone of the lung, and then we looked at how the patterns were changing across the different images. So this was the idea that we had there, and the goal was to take the initial image or take the first few time points of images and predict what will happen to the patient on day n. So that was the problem statement here. And we always need to have baselines, right? I mean, it's good to develop new methods, it's good to develop sophisticated methods, but you should always compare them with the simplest of methods or the more traditional methods that are out there. So one of the things that people have been doing, that everyone does, is some sort of a transfer learning, right? So by transfer learning, what I mean is you have a model, you have a deep learning model. Back then, even VGG16 was a good model. Nowadays, you have much better and much more powerful models. These models are used as feature extractors. So you extract features using the different models, and then you provide those features to, let's say, a simple classifier, and you train the model. Or you can start with pre-trained weights, and you take your limited data set and you keep training it or fine tuning it a little bit further and see how well the results are. So that was our baseline, and then we had our approach, and what we found was that clearly using our approach, an LSTM method would be able to provide better results than the baselines. Variant 1 and variant 2 were where we either changed or we remove the temporal block or the spatial block, and it's clear that if you remove them, it's not a great model. But that's just part of the story. What I want to talk about here is how do we bring domain information, right? So it's not just about getting the segmentations from the clinicians and training your model. How do we leverage that clinical insight? How do we leverage that clinical intuition during model training? So in the course of annotating these samples, in the course of curating this data, so one of my students, Aishik, who's here, he has disappeared after he graduated, by the way. So what he did was he sat with radiologists while he was collecting these labels, and when he during his conversation with the radiologist, what the radiologist told him was that there is a certain pattern in which this disease progresses. So usually the COVID infiltrates, they start in the lower lung and they slowly make their way to the upper part of the lung. Okay, and this got us into thinking that, okay, why do we not try to leverage this clinical information and build a module that can try to emulate this sort of a clinical finding, right? So what does this mean, and how can we model this mathematically? So what this means is that the disease patterns in the adjacent regions, so let's say that you have the lower left lung and you have the middle left lung, that these would be, the disease patterns here would be more similar compared to the disease patterns here, right. So, zones that are close to each other will have more similarity as opposed to zones which are further away from each other, simply because of the way the disease progresses. And this, see, when I tell you this, it sounds very simple, right, but just to get this information from clinicians, just to appreciate the fact that this can be a very powerful prior to your machine learning models, that wasn't simple. It was almost sort of an eureka moment that, okay, oh, this is something interesting that we can leverage in our models. And there's an important lesson here, right. So what this means is that, yes, you can ask, your collaborators might be somewhere else, you are sitting here, you can say, okay, can you just annotate this data for us and give it to us, I want to train my model, I'll give you the results. That's fine. Majority of us do that, but you'll see that, especially as a junior researcher, if you start sitting with your collaborators, with your clinical collaborators, understand how they are annotating this, what is the thinking that goes on behind getting these segmentations, getting these annotations, you will learn a lot. So myself, like I said, I'm an electrical engineer by training, and when I moved into biomedical engineering, even in my first project, I sat with neuroradiologists day in and day out. I sat with cardiothoracic radiologists just to understand the kind of the way they were annotating the data, and that gave me a lot of clinical knowledge. I wouldn't say clinical knowledge, that gave me a lot of domain knowledge regarding what are the different factors they consider and how we can make our models better, right. So maybe in the machine learning community they might not appreciate this, right, because they're all about volume. But if you want to translate some of these techniques that you develop into clinic, and you understand what goes behind the scenes in annotating this, what's noise, what's not noise, that will help you train a much better model. Okay. So what's the framework that we built? So we had a similar framework that you saw in the previous work, but we built this very simple module. This is a correlation module. So what this module does is it enforces a constraint that there is a high similarity between adjacent regions and there is a low similarity between further away regions. That's the only constraint that we incorporate into the model. So just by doing that, our results improved significantly. So these were our previous results, these were our new results. So we see that if we include this domain information, we can predict the severity with a much better precision and recall. Okay. So any questions so far?
So how did we incorporate that info given by radiologists?
So this is the information, right? So this correlation module that you see, so that module enforces that the representations that you get from the middle lung and let's say the lower lung have a higher similarity. Let's say you are doing a cosine similarity or something, so that have a higher similarity than the representations from the upper lung and the lower lung. So that's the information that you got. So that's the constraint that we enforce, nothing else.
So but at which portion of the algorithm we enforce that?
So it's right here after you get the encodings. So it's with respect to the encoded representations. That's what we do.
Okay, so it's part of that encoded
Yes,
representation.
yes.
Okay.
It's part of that.
Sir, actually, I have one question. Like, if we are doing pixel to pixel, like code, like similarity matrix.
It's
kind
region
of
to region.
Actually, it's region to region, not pixel
Not
to
pixel
pixel.
to pixel. Yeah.
Okay. So it's then it's fine. Like if it is pixel to pixel,
No, we cannot do
obviously.
pixel to pixel,
Yeah.
right?
Okay. Like it's like region 1 to region
Yes.
2, something like
Yes.
that.
So region 1 to region 2, region 1 to 3, 2 to 3.
Okay.
Like that.
Yeah. Okay. Done.
Sir, how do we separate the zones? Like, what is the protocol?
Oh yeah.
to,
So
like,
the protocol was you first once we get the segmentation of the lung, it's 1/3, 1/3, 1/3.
Okay.
Yeah. So it was an approximate division. Like we just took a 1/3 of the total length of the lung.
So can it be other than that?
So yeah. So there's something else that you can do. You can divide it into lobes because lung lobes are well defined, right? So you can have a lobe segmentation model and you can look at lobes. But since we saw that this progression was from zone to zone, we did it that way.
Were those patients of the same age group or?
No. So ideally we should do that. Ideally you should try to normalize for factors such as age. But here, first of all, the number of patients that we started out with, the number of images that we started out with was already so low. We did not divide them by age. We took everything that we had, but eventually we also used age as a predictive factor in our model. Yeah, but we did not divide them based on age.
Okay.
Yeah. Okay. So
we have one more, sir.
Okay.
Sir, that the goal was to predict the improvement based on the sequential image information. There were many cases where the lung infection they recurred after a certain period of the time. So were we able to predict those also, or were
Yes.
those information
Yes,
incorporated?
you're right. It's not that the for all the cases the infiltrates get better. There were cases for which it got worse. So we were able to predict for patients who it got worse. We were those were part of our testing set as well. Yes, so we did that. That's a good question. Okay, so next let me come to the aspect of learning in limited data scenarios, specifically devising models where you don't have enough data. So this again comes from observation. It's not something, it's not a kitchen sink that we applied here. We looked at images over time. What you see on the left is image of chest X-ray scan taken at day 2, and then on the right you see the chest X-ray scan taken on day 23. What you see here is on day 2 you find that by the way there's something else here. You notice this? That's not part of the lung. So this is a device, some sort of device which the patient has, maybe a pacemaker or something, or maybe some other artifact. It's important that before you use these kinds of images for training, you make sure that you have segmentation models that can remove things like this, because otherwise your segmentation model will or your classification model will start learning from these images. And obviously people who have some sort of leads or some sort of wires, there's something going on with those patients, right? They're already bad to start with. So your model will probably pick on those differences rather than differences from the lung. Okay, so this is a very important pre-processing step that you want to do to remove images like this, or not to remove regions like this from your analysis. Okay, so coming to what I wanted to say here, here's an image of when the infiltrates were not that much, and then on day 2, and in the second image that you see, you see these regions, you have these lung infiltrates here. So there's something that we observed here. So you see that if you take a region here, you don't really see much infiltrates, or infiltrates are much lesser in density. But if you see here, you see this whitish cotton wool like thing. So you see that there's a lot of infiltrates here. So over time you see that the texture of the lung, so we learned a lot about texture in the first lecture. So the texture of the lung tissue changes. Clearly the texture is different. If you apply the collage features, or if you apply some Harlick features, some filters, you'll see that the responses that you get will be very different from the dark region compared to the brightish region. I mean, it's not really brightish region. You see that there's some sort of a salt pepper like thing here, right? So you see that the texture is very different. However, if you look at the structure of the lung, you see that the structure of the lung remains same. Right, the outline of the lung, the structure of the lung remains same in this disease. Again, just this disease. There are diseases where the structure of the lung changes, but in this particular disease, we saw that for the most part the structure of the lung remains same. So, so what we wanted to do was, so this observation was that the in-lung texture correlates with infiltrate levels, while the lung structure remains unchanged. So this actually gives us an important opportunity, a very interesting opportunity to use or to develop, to generate synthetic images that can have the same structure but different textures, and that's what we did here. Okay, and I won't really go into details of what we did here, but I'll explain to you how we got it. So, image 1 is from patient 1, is from one patient where you have some sort of diseases. You see that there are diseases here, there are diseases here, like there is some infiltrates here. Image 2 on the right is a healthy lung. You do not really see any diseases here, like no pneumonia, nothing. You see it is an example of clear lung. So, what we did was we took the structure of the first lung and the texture of the second lung, and we generated this hybrid image. So, this hybrid image that you see here, you can clearly see. So, let us say that this is the structure, you clearly see that this is the same structure, right. So, we retain the structure, but the texture of this is same as the texture of this, right. So, what you see is that this is an artificial image that we have created that has the structure of one and the texture of two. Now, you can ask me, why did not you do the other way around? We did that as well. So, we took the texture of the first lung and the structure of the second lung, right. So, you see that there is some texture information here, we tried to mimic that texture information here, and we retained the structure here. You can clearly see that the structure here is the same, right. So, we can basically mix and match and create these hybrid images. Now, why do we create these hybrid images? Because we want to increase our data set, right. So, we want to artificially augment our data set, because a lot of times you do not have enough samples to train your model. If you can artificially synthesize these images and you can use these synthetic images for training your model, the hope is that the model will get better. So, the first step was, or the first task was, pulmonary disease classification. So, it is not just disease, it is not just augmentation of the different data sets, but at some point when you do this, you will learn an encoder, right. You learn an encoding. If you want to learn an encoding representation, you have to train an encoder. So, just by using that encoder as a feature extractor, we found that our model was performed quite similar to state of the art models back then, which included Inception V3. But what is more interesting is that we had much fewer number of parameters, which means it was a much faster model to train. Coming to outcome prediction, we had another task where we wanted to predict if a patient will need mechanical ventilation or a patient will not need mechanical ventilation. And so, we have the balanced error rate and the AUC. We found that just our encoder LSAE is our encoder, lung swapping autoencoder. Our balanced error rate was much lower, and we had a pretty high AUC compared to the Inception V3 framework. But the more interesting thing here is augmentation. So, we can use these hybrid images that we created to augment our training set. So, like I said, if you remember the cats and dogs example, right. So, it's more like taking a cat, making it look like a dog, or the other way around, and you can use it to train your model, so that you provide some sort of additional variability to your model. So, that's exactly what we did here. Coming to attention mechanisms, we had a question or an observation in the first lecture. What you can also do is you can back propagate your model weights, your learned model weights, and you can see which part of your images the model focused on more. And we found that for a lot of cases, or for a majority of the cases, so this red arrow that you see here was the region where the disease is present. So, the red arrow was given by a radiologist, and here are the model attentions, or the high attention regions that you see here. For most of these cases, you see that the model attention is mostly localized to where the disease is, but there are cases of misclassifications, as there is with any other model. In fact, I think the director today said that there can be cases where the model gets it wrong, and evidently the model does get it wrong in multiple cases. And we can see how not just the model, it's not just that the model is getting it wrong, but also the attention pattern is a little bit all over the place. Okay, so we need to do all of this post hoc analysis to understand where the model is learning from. Okay, so let me talk a little bit about treatment response prediction. So, if you remember, we spoke about disease diagnosis, prognosis, and treatment response prediction. So, one of the important one of the important aspects or one of the important unmet clinical needs is predicting response to different kinds of therapy. So, why is that important? So, like I said in the earlier lecture, newer treatments are being discovered every day. So, if you read the news, you will see that every day the FDA or other regulatory bodies, they are approving different kinds of new treatments. Immunotherapy is one of the more recent treatments. So, immunotherapy has been found to be very effective in cancers like skin cancer, in lung cancer and so on, and nowadays there are trials going on in brain cancer, multiple different cancers. But why is it important to understand, or why is it important to predict response to immunotherapy? Because this is a very expensive drug. I don't really know much about the reimbursement scenarios here in India, but at least in the US, where insurance has the final say, a lot of times these newer modalities, they might not be reimbursable by insurance, which means that a lot of times patients have to pay out of their pockets. And for a lot of these new treatments, which a lot of times are experimental in nature, they can be upwards of $50,000 per dose, right? So, it's very difficult for not just for patients. I mean, there's a lot of financial burden here, but also like from a clinical perspective, there's not much that a doctor can do. I mean, there are a few molecular markers like PD-L1 status, for example, and doctors look at this status to decide who to treat and who not to treat, but it's not a foolproof marker. So, what if we can use imaging to tell with some conviction, with some degree of certainty, that here are the patients who will respond and here are the patients who will not respond? And it's not that simple. I mean, if we can do that, then problem solved. We can't really do that. We can, what the best we can do is, what is the probability that patient X will respond and what is the probability that patient X will not respond, right? It cannot be 100% or 0%, right? So, and the doctors have to make an informed guess based on this and the clinical history and other sort of factors, whether to give a treatment or not. Anyways, so coming back to the questions, it's not just who to treat. Before treatment, if you can tell whether a patient will respond or not, that's good. But a lot of times there is the level of response that you see in patients, it varies. So, for example, for some patients, as you continue treatment, they will keep getting better and better, and these are not a single, this is not a one time drug. You have to give the drug over time, over a few months, like maybe 2-3 doses or something like that. So, there are certain patients who will respond, but for a certain group of patients, you will see that only after a few doses, you will see that then they're responding and they stop responding, or they don't respond after a few doses. So, you need to know where to stop, right? It's not just saying who has to be treated, but it's also to evaluate should the treatment be continued or not, and that's again another important question that clinicians need to answer. So, there is a lack of biomarkers to identify which non-small cell lung cancer patients can receive maximum benefit to from immunotherapy, and also there's a lack of objective methods to assess the immunologic benefit from these immune checkpoint inhibitors early, so that patients who are not responding can have the treatment changed. So, first I will talk a little bit about some of the radiomic analysis that we did, the texture analysis, if you remember the collage features. So, what you see here is an example of a baseline scan for a patient who did not respond to therapy. So, this image was taken before immunotherapy was given to the patient. Another snapshot representation of a patient who eventually responded to therapy. So, if you look at the two images, you will clearly see that based on the images, you can't say this patient will respond or this patient will not respond. They look so similar to each other. If you look carefully, you will see that the lung lesion is here and the lung lesion is right here, okay? And the sizes are similar, the texture, just by looking at it, the texture looks similar, the intensity looks similar. So, what we did was we computed the collage features, and you see that there is some level of difference of the collage features for the patient who responded to therapy and patient who did not respond to therapy. But what was more interesting is that after therapy was given, when the patient came for follow up, if you look at the texture differences, you clearly see that the non-responder had a different change of the radiomic features as compared to the responder. For the responder, you will see that the radiomic features probably did not change a lot. For the non-responder, they changed a lot, right. So, you clearly see that there is something that is happening to the texture of the lung that is different between the responder and the non-responder. And also we will cover a little bit about tumor infiltrating lymphocytes in tomorrow's lecture. But if you look at the lymphocytic infiltration patterns, so lymphocytes are essentially the immune mechanism, the defense mechanisms of the body. Okay. So, if you look at the lymphocytic patterns of the responders, you will see that they are much different compared to the non-responders. So, in the responder they are more compact, in the non-responder they are sort of more spread out. So, which means that there is some connection, some connection between the lymphocytic infiltration pattern of the responders and the corresponding radiomic features, and that is something that we try to investigate using this plot, where we showed that higher expression of certain radiomic features are reflective of different infiltration patterns of lymphocytes. So, again the goal here was to develop multimodal pretreatment predictors of response. Okay. So, I will talk a little bit about tumor associated vessel architecture. So, what is angiogenesis? Anyone? Formation of more blood, formation of new blood vessels, right. So, angiogenesis or formation of these blood vessels, it's one of the important hallmarks of cancer. And why is that? Because when these, yes.
My cancer is progressing, so it helps in the cell division and the blood flows also, the cell will also get the food and
Yes.
the network is formed.
Right. So, what happens is when you have these newer blood vessels forming, the blood vessels basically become a conduit for the nutrients, for the food to reach the cancer, and the cancer sort of thrives in that environment, right. So, angiogenesis is a very important hallmark of cancer. What this means is that it is important to study the structure of the blood vessels. So, just by looking at this image, so you see, by the way, this is a DC MRI scan of the breast. So, on the left side is the right breast, on the right side is the left breast, and the yellow region is the tumor. So, the red segmentations are the blood vessels that are sort of feeding the tumor. So, just by looking at this GIF, what are the different properties do you think can be extracted from the blood vessels? Anyone?
Pattern of the blood vessels in the tumors.
So, what do you mean by pattern?
Like how they are spread across different regions, and where they are connected, how they are connected.
Spread, how they are connected. Good. Anyone else? So take a look at it again, or maybe I'll look at this. What can you compute? Yes.
How large they are?
How large? So something regarding the size, right? So regarding the morphology. So how large, how they are connected, how dense they are. So all of these are valid measures, and all of these measures have been studied, and we have also studied these characteristics of these blood vessels, these morphometric or these morphologic characteristics of these blood vessels, to see which patients will respond to cancer, which patients will not respond to cancer. So if you remember, we had that one slide on neoadjuvant chemotherapy response to breast cancer. So we found that if we study the patterns of these blood vessels, the tortuosity, the convolutedness of these blood vessels, they are different for patients who respond to cancer and patients who do not respond to cancer. And these are the biomarkers, these domain inspired biomarkers that clinicians can understand. Like if you give them deep learning features, they will be like, okay, how do I make sense of these features, right? So those features intrinsically do not mean anything, but features like this are more intuitive. They have an underlying grounding in the clinical, in the pathophysiology of the disease, and that is what we want to understand here. Okay, so the goal here was to predict response to immunotherapy in lung cancer. So what you see on the top here is an example of a patient who eventually responded. This was an image taken before treatment was given to the patient. Here you have an image of a patient who did not respond to immunotherapy, again image taken before the treatment was given. We used a deep learning model to segment out where the tumor is, and another deep learning model to identify the blood vessels. So, here you see the blood vessels and you have the tumor in the center. So, if you just look at how dense the blood vessels are for the responder and non-responder, you clearly see some difference, right. You see that the blood vessels are probably denser in one of the cases compared to the other case, but what is more interesting is if you look at the tortuosity. So, tortuosity is nothing but the degree of convolutedness, how twisted the vessels are. So, our hypothesis was that blood vessels, the nature of the blood vessels, how twisted they are, would differ from patients who respond to immunotherapy and patients who do not respond to immunotherapy. So, as it turns out, the responders have a lower tortuosity as compared to the non-responders. So, the responders that you see here, you see that the blood vessels are sort of more or less tortuous, less convoluted, less twisted as compared to blood vessels here, where the convolutedness and the twistedness is much more. Now, any of you from the electrical engineering department or have taken courses in electrical engineering, or do you remember fundamental concepts of, let us say, resistance in electricity? Some of you do, right. So, I am an electrical engineer by training. So, putting my electrical engineering hat on, what this means is that the patient here up here, the blood vessels are less tortuous. That means there is probably a lower resistance for the drug to reach the tumor, which means because of the lower resistance, the drug is probably acting on it the way it should, and we are getting a response, the desired response, as compared to the non-responder, where you do not, or where you have a much higher tortuosity, higher resistance, which means the drug is not being able to attack the tumor the way it should, right. If this is true or not, we do not know. This is obviously some sort of a let us say hypothesis. The only way this can be tested is using maybe mouse models or animal models, but this is potentially or probably why this is happening. So, what we also did was we looked at how the tortuosity changes after a drug has been administered. So, just look at the first row here. So, the blue line is essentially the tortuosity before treatment, and the red line is tortuosity after treatment. This is for responders, this is for non-responders. So, just by looking at the top two images, what does it tell you? So, just look at the blue line, look at the red line for the responder and the non-responder, and tell me what you conclude.
There is significant difference between the pattern before the treatment and after treatment in the responders as compared to the non-responders.
Okay, and what's that significant difference? What's happening? What's going up? What's going down? Like, where is it changing?
So, the before treatment, the tortuosity is higher in the responders, and after treatment it is lower, but
Right.
in the non-responders it is pretty much at the low range.
Yes, good. So, as we can see that for the responder, we can see clearly that the tortuosity goes down after treatment, but for the non-responder it is sort of similar, and in some cases and it's like in some cases it goes down, but in some cases there are cases where it slightly goes up as well, right. So, what this means is that after the drug attacks or after the drug acts on the tumor and probably the tumor microenvironment, there is a reorganization of the vasculature, right, because of which the nature of the twistedness, the nature of the tortuosity actually changes. So, this is what it tells us. And these are features that clinicians do not consider, but clearly if we use these subvisual biomarkers, these radiomic features, these tortuosity based radiomics, we can provide the clinicians with some added information regarding the tortuosity of the vessels. And what QVT1 is, it's one way of computing the tortuosity, it's one feature. QVT2 is another feature. So, you can have different ways in which you compute the tortuosity, right. So, these are just different ways of doing that. Okay. So, the next question is temporal imaging. So, we had this one use case where we looked at temporal imaging in the context of COVID-19. However, it is very difficult to obtain temporal imaging for all the use cases or the different clinical conditions. So, question for you guys, what information about disease progression is lost when we treat medical images as independent snapshots? Anyone? Because, okay, so let me try to simplify this. So, if you look at a lot of or majority of, let us say, publications or research that is out there, they all look at a single time point imaging, just one image per patient, one image per patient. So, if you have that one image, what information is lost?
How disease progressed, that is lost.
So, yeah. So, what is lost is how is the disease getting better or how is it getting worse over time, similar to what we saw in COVID-19. So, there is another response, similar response, right? Yeah. So, we lose information regarding the trajectory of the disease, and there is a lot of signal that can be obtained just by studying the trajectory of the disease. So, here I would like to talk to you about or give the analogy of how a doctor, how a clinician looks at these images. So, let us say that you go to a radiologist today, they would look at your scan and they would say, yeah, I mean, here is the findings today, let us maybe there is certain treatment that goes on, and they will come back for another scan, they will look at the second scan. But if you know the way the radiologists work, they tend to remember what they have seen previously. Okay, so, they make the decisions not just based on this one image, but also based on previous images that they have seen, and not just that. So, I am a patient who comes in today, my doctor looks at my image, maybe my doctor does not have access to my previous images, or maybe I do not even have previous images that have been collected, but there will be other patients whose image looks similar to mine, and those patients will have previous images collected. So, the doctors can actually contextualize your image with respect to serial images of other patients, right, and that is the idea that we try to bring into this piece of work. Yeah, usually, like I said, most literature is focused on snapshot image machine learning, where you have just image taken on one day, one snapshot image per patient, and we want to do tasks like outcome predictions. There are many data sets, large data sets, not as large as ImageNet, but pretty large data sets, and like I said, most clinical prediction models use only snapshot images. Temporal images are very limited, and temporal images can be like serial lung CT scans, serial MRI scans, typically for Alzheimer's disease. There is this ADNI data set, you can look it up. You have images taken for patients over time to look at how cognitively they decline over time. You can have sequential chest X-ray scans like our COVID example that we saw in our earlier slides. So, temporal data sets contain important information regarding the progression of the disease, regarding the disease trajectory, but they are limited in nature. There are very few data sets that have temporal imaging, and also there's the question of consistency. Like I said, some images, some patients will have 10 images, some patients will have 20 images, some patients will have only 2 images. So, there is a lot of inconsistency there, and what happens is often you do not have temporal images in the testing phase. So, when you have a model, you have trained your model on, let us say, temporal images, thousands of temporal images, each patient has 10 images or 20 images, but when it comes to testing the model, you only have one image, right. How do you do that? How do you infer, how do you use that model for inference that has been trained on temporal images but only has snapshot images? That is what we try to do here. We wanted to jointly exploit the complementary information to improve prediction. So, the goal was to design a framework that utilized partially available temporal data to influence the feature learned by single time point prediction pipelines. So, let me go back to the analogy of the radiologist looking at snapshot scans versus temporal scans. So, I come in today, the radiologist looks at my scan, tries to understand whatever they want to understand, get their they try to get their reads, they understand what is going on in that image, but they try to calibrate what they are inferring from this snapshot image with respect to the temporal images that they have seen previously. There is some sort of calibration going on. They are not drawing their conclusion based on today's image only. They are trying to understand the features and calibrate today's interpretation based on today's and previous prior knowledge, and that is what we want to do here. So, first we utilize a hierarchical attention mechanism in temporal convolutional networks to select the most informative image from the entire sequence in the training, and then how do we align these distributions? We employ an MMD loss between the two different domains. So, here is an overview, this will give you a better picture. So, you have, so these are knee scans, osteoarthritis, these are knee scans. So, we have sequential images, we use a temporal convolutional network to learn the pattern of disease progression, and we obtain the most optimal representation. We have a snapshot learning where you have only one image and you use a vision transformer or any other your favorite feature encoder, then you fine tune that based on the data that you have, and then you match your temporal representations to your snapshot representations. So, just based on that, by looking at or by learning from temporal scans, we see that our results become much better compared to models that do not that are not exposed to temporal scans. And this was good for COVID-19 ventilation and mortality prediction. This was also found to be true for osteoarthritis severity prediction, and this was actually done using a osteoarthritis Kaggle dataset. Now, quantitatively what we found here was even more interesting. On the left, what you see here is a TSNE plot. It is a reduced dimensionality representation of the features of patients who got mechanical ventilation and patients who did not get mechanical ventilation, and we see that even though there is some separation, you do see a lot of mix up between the red dots and the blue dots. But when we used our temporal learning framework, we found a much clearer separation between the ventilated patients and non-ventilated patients. So, what this tells you is that there is additional information being brought in by the temporal scans which can help modulate the snapshot representations. That was also true when we looked at the class activation maps. So, without temporal, you have a much more dispersed map. With your temporal information, you have a more localized attention. Okay. So, I think that is it for this session. Any questions?
Sir, any morphological operations you are done with that?
Sorry?
Morphological operations, sir.
Morphological operations?
You are not?
Not. So, not in this particular context, but in the lung vessel segmentation. So, just to obtain the segmentations, to clean up some of the segmentations, we had to do a lot of erosions and dilations. Yes.
I have one question.
Yes.
It's kind of a basic question. So, you see, like you mentioned, as you move from data set to data set, model performance either deteriorates or it doesn't change much.
Right.
So it depends on the image, I guess. So, like in a realistic scenario, from a deployment perspective, so you have to train your model on a golden data set, so to say.
Right.
But then how do you make it adaptable to the real life scenario? Let's say you deploy it in a hospital. How does the model perform as good as, or at least the acceptable performance? Are there any steps to keep in mind, basic points to keep in mind?
Yes. So one of the things that we need to do is, obviously we have to do a prospective validation, with your models that have been trained on some data set. When you finally deploy it on the clinical side at clinic A and clinic B, you have to do some validation on a few initial studies to see how the model performs, and then you evaluate the distribution shift, right? If it's very different, you look at the data set. If the data set is itself very different, the intensity distribution or the intensity profile is very different, then it's evident that the model will not work. But if your model works, but it doesn't work as expected, one of the things that you can do is you try to devise techniques to take your model, use it as a baseline model, and try to fine tune it with limited exemplars from your clinic, and try to see if that works well. Otherwise, I mean, what are the other techniques? You can take you can obviously take, you know, more than a few cases. You can take a bunch of cases, put that into the entire training set and see if it works, but that beats the whole purpose, right? So what one would do is probably some sort of an active learning scenario, where if it's for segmentation, if your segmentation model doesn't perform well, you apply your model, segment it. There will be regions, small regions, where you'll need some sort of a correction. You just provide examples like that and actively retrain your model and try to see if it works well.
So just an additional question.
Yeah.
Based on your experience, are there any standard pre-processing methods which can ensure reproducibility of models? Like, since you have worked in, let's say, COVID dataset and the other datasets, so based on your experience, are there any?
So that again varies from domain to domain. So I'll talk about MRI first, brain MRIs first. So in brain MRIs, we have to do a lot of intensity matching. We have to standardize intensity. So there are standardization techniques that we have to follow to bring site 2 to the same space as site 1. So that's with brain MRIs. In digital pathology, which I'll be covering tomorrow, there is something called stain normalization. So if you look at some of these digital pathology images that have been stained with hematoxylin and eosin stains, you'll see that some images are very pink in nature, some images are less pink. A lot of times that can happen due to not just variability in scanners, but also the technician who's doing that. So some technician might give a lot of dye, some technician might give less dye to stain that image. So there's something called stain normalization, where we try to normalize the intensities of the different images and bring them to a common space before we apply any machine learning tools. So that's one. Other kind of pre-processing techniques, you can ascertain in the context of digital pathology, you can ascertain the regions where you have noise which are out of focus, because when you scan under the microscope, sometimes you'll have out of focus regions. We can take those, either remove those regions or maybe use generative AI techniques to fill those regions or super resolve those regions, and then do your processing. But yeah, I think it's a horses for courses approach. There's no fixed technique, but methods like stain normalization, intensity matching, these are standard techniques that can be applied to most data sets.
Sir, I have a question. Like you have talked about the spatiotemporal LSTM based method. So there are many other machine learning methods like random forest. There are many more machine learning models like random forest and many more. So based on what parameters we are going to apply, like here we have applied LSTM. So are there any other parameters that we can apply different kinds of machine learning models?
So if the question is, let me see if I understood the question. So you're saying that there are models like random forest, and then what we applied was LSTM. What dictated the choice of our approach, right? So yeah, so random forest is nothing but a classifier, right? So random forest, what is a random forest? So random forest is essentially a collection of different decision trees, right? So you have different decision trees, and there's some sort of an ensembling technique like a majority voting or something that you use to average out or to combine the decisions of the different trees to come up with one result. But there is nothing intrinsic to a random forest that says temporal. Right? The entire approach here was to model the temporality of the disease, and that's why we chose this. Once you get your representations, you can always use random forest as a final classification step. No one is stopping you from doing that. Yeah.
Actually, I was just trying to understand from Beg sir's question, like can't we do the model versioning to kind of to keep the reproducibility for productions?
Can't we do model merging?
Model versioning.
Versioning?
Yeah. Like model freezing, maybe to the point we are rolling out to production, and then maybe once right, we see the drift with the existing versions, right? By the time we'll have the maybe retrained version as well, and maybe comparison based on that.
I mean, I think versioning is something we do all the time, right? So can you be a little bit more specific? Like how can versioning solve this problem? So I think Dr. Beg's question was, when you go to a new clinic, so you might have a wonderful model that works on clinic 1. As soon as you go to clinic 2, there might be instances where it does not work. So how does versioning solve?
No, I think I then misunderstood the question. So I was thinking that over the period of time, if the model does not perform well, so how can we solve that part? that part.
I see.
Kind of get the drift of your question. So
Drift,
like
again, pun intended.
yes. So like for example, as we evolve, like as more and more challenging images come in picture.
Yeah.
So how do you make sure that the model keeps up its performance? It doesn't degrade over time, right? As you know, as it's similar case. Like for example, you know, if we are doing some sort of a recommendation system.
Right.
So over time, people's choices actually change. Then you have to train the recommendation.
Yeah, you have to. I mean, yes, very valid question. But if you have cases like that, you have to do, you know, you have to apply techniques like domain adaptation and see. You have to first need to have a handful of cases for these difficult cases, and then you do some test time adaptation, right? There's not much training. There has to be some test time adaptation to make sure that the model becomes better.
Question I'm having, like I think in AI world, what we see is that the models that was trained on the other part of the world, right, that do not tend to perform on the maybe this country, or so. I mean, is that still applicable for the medical data as well?
It's more applicable for medical data than non-medical data, and there's a reason behind that. So I was actually at Tata Memorial Center, the Cancer Center in Bombay 2 weeks ago or 1.5 weeks ago. One of the very interesting observations by the clinicians there, by one of the pathologists there, was that in the in countries like the US, they take resections of lung cancer, for example. But in India, a lot of times, or the majority of the times, you just take biopsies, right? So you do not capture enough tissue. It's just spots that you capture, right? So obviously, a model that has seen more context will not perform as well on the data that does not have that much context, right? So a lot of times you don't have the similar kinds of data preparation. The data preparation itself differs, which means that the model that has been trained on that data will not be that good, or will not be as efficient as you know, as a model that has been tested on that data, right? So that does make a difference. Yes.
Okay. All right. Thank you.
Sir, I have a follow-up question regarding what he told. Like how, because the ethnicity is a very big problem in the medical data, I guess. Like the datas of European countries and their population that can't be applied in Indian population and all this. So,
yes.
So how it is going to solve, like if we are using this in the America,
yes,
and then how this model is going to work in India?
Oh, very good question. So a lot of that also needs domain adaptation. So, but and you're right. We have seen this. There are I can point you to multiple papers that have shown that models that are, let's say, trained on Caucasian populations don't work as well on African American populations, right? So why is that the case? Because probably the training set probably does not have enough representation of the African population. If it did, then the model would possibly do well. So there are two ways of solving this: either do some test time adaptations, or try to, you know, build separate models, right? Build models that are specific to Caucasians and build models that are specific to African Americans, right? So in fact, this actually brings an interesting story to mind. My dad was just telling me this 3-4 days ago. When I was interviewing, like when I was just getting into school, like for nursery standard, I think the principal showed me an image of a dog and asked me what it was. And I told them that it's a wolf. Okay, and it was a German Shepherd, an Alsatian, which looked like a wolf. But obviously back then, you know, I had only seen street dogs, right? So my model was trained to recognize street dogs, and for me, wolves were something that I'd seen in pictures, in images, right? So obviously I couldn't recognize that it's a dog. So it's a very similar idea. Unless you give some examples to your model and tell the model that it is of another particular class, then it's impractical to expect that it will do well, so which means you have to either retrain a model or fine tune the model.
Sir, my question is about augmentation. I have a long haunting question that
You said long haunting
long
question.
yeah,
Okay.
it's been in my mind from a long time that
Okay.
I was not able to decide whether to use the augmented data in medical field. Like how reliable you think that like the augmentation train your model, like how reliable are the results?
Yes,
like I
yes.
always have this feeling of like can we really use that augmented data in the medical field, or
Right.
like in some sense like we are feeding the
Yes.
wrong data?
Yes, yes. I think that's a very valid question, and this is the kind of thinking that we should have as medical imaging researchers. It's not just about augmenting these images and providing them to your machine learning model. There is a step in between that I did not discuss. When you generate these augmented images, one of the more important steps is show these augmented images to clinicians and get feedback from them how good these augmented images are. Like, is this just a random image, or does this image actually look like a chest x-ray scan? Does it look like a digital pathology scan that retains the important characteristics of that particular disease? If the clinicians are convinced that this is an image that is as close as possible to real image from multiple different fronts, only then we should use these images to augment our data set. Otherwise, I think you rightly said that we can introduce inadvertent errors, right? It's not just augmenting it randomly and providing it to a model. We have to make sure that these augmentations are indeed correct depictions of that augmented class that we want to provide. Yeah.
Because I have seen like most of the papers, they're using the the basic geometrical transformations of like CT, MRI, or any kind of histopathological data, and then they are training their model and presenting the results. But like I have the question like how valid are these results?
So that's a slightly different question. You are talking about these transformations during deep learning model training, right?
Yes, it is.
No, so that's a different question, because there we want to make sure that the model is invariant to these transformations. So let's say that you have some cropping going on, or some rotation, some sort of a translation. So you do these at a patch level, or at a usually at a patch level, to make sure that you are providing enough variability to that data to make it these transformation invariant. But that is slightly different than what I am talking about from a
I get it, but like again, my question is like we cannot actually reproduce the synthetic images in the real world, right? Like let's say I have a CT image, or I have geometrically transformed, like stretched, or like or like any other kind of augmented thing. That is not possible in the real world, right? Like
right.
So like how do we think that like we are training the good data to the model? As you rightly said in the initial stage, like we have to feed the proper data. Like we should not have any kind of what do you say, that like corrupted or like properly labeled and properly processed data to the model. But like how could we be so sure that like this stretched or like transformed image will give you the better result, will give us the better result?
So I don't know if I have a good answer to that. What I would say is, when it comes to a model training, when we are doing these augmentations like stretching, rotating, or whatever, we want to generate enough variations of that training data, and then when we train an encoder, we want that encoder to be trained in such a way that it is invariant to how that patch is being showed to the model. That is what we want to do. That is a slightly different question from the generative AI techniques that we use to get synthetic examples of a particular disease, right? Yeah, because yeah, but if you do these transformations like rotation, stretching, or whatever, I don't think we can, like, even if we do that experiment with radiologists or pathologists, they'll say that this is a rotated image, this is a synthetic image. Yeah, so there's no way that will fly. But yeah, I understand your question. I mean, yeah, it's a valid question. Yeah.
So just to add to his answer, I came across a paper. I will share it in the group also, which actually investigated. Let's say, so instead of talking about image augmentation, so sometimes we face the problem of limited data sets.
Yeah,
So
yeah.
how much augmented images we can use? So they have come up with a ratio. I will share it with you. Maybe that might have some, give you some better insight.
Yeah.
So yeah, just so before we break for tea, just one last request to all of you, to you actually, Pratik. So since the lecture, as it's a long lecture, so what I would request you is please summarize it in 2 or 3 points so that
Okay.
the gist remains in our minds.
Okay, so let me think about what I spoke about. Yeah. So yeah, so I think the second lecture was all about how do we bring in domain knowledge into the clinical, into the machine learning training paradigm or the machine learning workflow. So I think to summarize it, what I would say is we need to understand if there are some clinical priors that can be helpful in model training. Like we need to sit with the clinicians, we need to understand, let's say, how the disease progresses, and try to see if the information that can be learned from clinicians can actually help in making our models better. And that's the crux of what we learned in this particular lecture.